with no warning symptoms at all. Cardiovascular Institute of the South is the leader in treating cardiovascular and peripheral vascular disease. If you think you may be at risk of having a heart attack, come see us at any one of our 11 locations.
Welcome back to our live call-in show from Cardiovascular Institute of South at Appaloosas General Hospital. This is a live call-in show, but I know this is a difficult time for people to call in, but those of you that tuned in late, tonight we are discussing about abdominal aortic aneurysm, both the diagnosis and treatment, and in the first 3 quarters of the show with Dr. Fail and Dr. Orzola, we went on and discussed what are abdominal aortic aneurysms, why do we need to worry about them, how do you diagnose them, how do you go about treating them, surgery or endografting, and then what are the other non-surgical, non-treatment options if the aneurysm is not large enough, what are the ways to treat it. We talked about all these aspects in the first portion of the program here. Now we are at the last few minutes of this program. We'll go ahead and discuss about, once we finish the endografting of the aneurysm, our job is not over. So Fernando, I want you to please educate the audience as to how to follow up these endografts. What are the simple methods that besides clinical follow-up, it's a...
Basically, again, the basics. Pressure control, heart rate control, getting rid of the cigarettes, getting your diabetes controlled, getting your cholesterol, the same things you would do for any type of vascular disease. I tend to follow them with a CTA periodically. Now, I won't do it every 6 months, but I will do it at least once a year to try and see that everything's okay, that we're not having any leaks, that we're not having any problems with with those stents, because you can have problems down the line. I'm not an expert in that field. That's Dr. Fail's territory more than mine. But that's basically how I will follow them. I don't use ultrasound after it's been repaired, because that's not going to help me at all.
Peter, what are your thoughts about ultrasound? You hear some of them talking about ultrasound as a means of follow-up in order to avoid the exposure to contrast and radiation.
There's definitely a role for it. I think, I like Fernando, I tend to do CTs because I do look for endo leaks, and I think ultrasounds are very operator dependent. They're also patient dependent. So in an extremely small, skinny, young lady whose aneurysm you felt at the time of exclusion, who's now you don't feel a pulsatile mass, I think an ultrasound works really good, and you can basically get some sizing issues. You may not see an endo leak, but as long as the aneurysm is shrinking, the endo leak becomes less important at that point. I think in the obese male, then again, it becomes very operator dependent, becomes patient dependent, bowel gas, etc. So it becomes a little bit more of a challenge to try to really see that aneurysm clearly.
Correct.
And really what you want to know is, did you do a good job, number one? Number two, has there been a conformational change? As this aneurysm shrinks, we'd like to see that aneurysm sort of shrink this way, but it doesn't. It sort of shrinks in a very contorted way, and so sometimes we'll see these grafts do very, very funny things. And so we can see these very rigid structures literally bend, and they'll kink on a rare occasion. They will separate on a rare occasion. There is an endo leak we talked about, and so anytime you hear the word leak with aneurysms, you're always a little bit nervous. But an endo leak basically is a repressurization of the graft itself, of the aneurysm. So it can come in several different methods, but the most common is what we call type 2, which come from a vessel to a vessel. And if you think of the aneurysm, before the aorta was aneurysmal, there were a lot of blood vessels that sort of came off of this, not only to the kidneys and to the stomach, but to the back and stuff, and most of those clot off. The clot we saw on the CT scan, most of those clot off. On a rare occasion, because of the pressure differences, one of those vessels will open up, and another vessel will open up, and it becomes basically a pathway coming from maybe somewhere in the pelvis or somewhere above the kidneys, and comes all the way through the intestines back into the aneurysm. And so when we see the CT scan, we'll be able to see a very light color where flow is going. And so I tend to do a CT scan a little bit more frequently. Now, I have patients who have some dye issues. I have some patients that have some kidney issues. So a lot of times we'll get a non-contrast CT and just measure size, and knowing full well that if it's gotten bigger, then we have to consider why is it getting bigger and start talking about a CT with contrast. If it's gotten smaller or stays the same, then we may do one in 6 months and look again, has it stayed the same with a non-contrast CT? And if it is, or it's getting a little bit smaller, then sometimes I'll feel comfortable that I don't necessarily need to know that there's an endo leak. And it's an individual patient. You have to look at each case as an individual. You can't say, I always do it this way or I always do it that way. So I think there are a lot of different scenarios that we'll use with CT, with ultrasound, with non-contrast CT, trying to make sure that we're doing a surveillance. And I think that's the part that also you brought up, that we really need to maintain a surveillance. And so sort of my regimented follow-up, if I will, and I'll tell my patients that the day after we get the day after we do this, at 1 month we're going to do a CAT scan. We used to do one before they went discharged, but a lot of times we would see some dye in the sac. We wouldn't know what it meant. So we basically said, let's go for 1 month. We would make sure they didn't have a type 1 endo leak, and that would be at the very attachment sites. But at 1 month we would look at it, and that would be our baseline. And then if that was normal, if that looked okay, the graft was okay, then we would decide on 6 months or 1 year. And then typically we'll follow them once a year for 5 years. Once we get to the 5th year, then it becomes a little bit of a question of what's happened to the aneurysm. And the aneurysm's gotten smaller than a lot of times. In fact, we have a lot of patients where you look at the CAT scan and the only thing you see is the endograft. You don't see any aneurysm whatsoever. And in those cases, I don't feel necessary to continue doing CAT scans. Now, the ones that have been 7 centimeters and 5 years later, they're still 7 centimeters, I feel comfortable they haven't gotten bigger, but I feel uncomfortable in not surveilling them more frequently. So I may tend to see those. Maybe we'll push it out to 18 months, maybe 2 years, but I need to maintain some sort of a surveillance program on those patients.
Definitely. I mean, of course, with the simplification of procedure with these endovascular methods comes the need for a more careful follow-up at the stage where we are in this whole game. If it's a surgery, there is no need for meticulous follow-up, but the initial procedure is pretty morbid. But once that is successfully done, the need for follow-up is barely minimal. I mean, once there's successful surgery and everything goes well, there is no need to do CTs, no need to do anything. Other thing about endovascular methods is that there is a small but sure incidence of failure, be it endoleaks, be it migration, as you said, as the graft, as the AAA or the aneurysm morphs itself or changes in shape, even though it is not growing, it is twisting, so anatomically it tends to pull the graft components, because grafts are not just one piece like a surgical graft. They're modular, typically at least 2 pieces and sometimes more pieces. So there are joints to these, and then as the sac migrates, it can just pull the proximal portion of the graft, or the portions in the middle where there is this modules are connecting can all get separated. The only way that we can really see them in the clearest fashion is just a CT scan. So there is, while as you said, in those cases that you feel fairly confident that the sac has shrunk, all I can see is the graft. It's been many years and this has been very stable, and the patient is 89 years old. Right. And you feel you have to weigh the risks and benefits of repeating exposure of this patient to a CT scan, radiation, and the contrast, which is toxic to the kidneys also. Versus a younger person, thankfully it's not a disease of very young people, but in a younger person, probably the burden is on us to make sure that the patient's graft is still functioning well. We may live with this, or the patient may live with this false security that everything is okay 2-3 years down the line, whereas there is some other problem with endo leaks and other things. So that there is a important point that you brought up, that there is a due diligence once we do the CTs. It is absolutely important that we track them and follow them methodically. And that's what all of us have a database.
I think that's one of the parts. One of the big trials that looked at endovascular intervention versus surgical intervention was the DREAM trial. And the DREAM trial basically said that they're about equal here and there, and there was no clear winner. But what was really the downside of endovascular was repeat intervention. And so it was that group of patients who did have an endo leak or who did have a migration that you needed to either put in a cuff, add another piece. Now, still, again, that's one one day in the hospital as opposed to a very morbid surgical up front. But it's what adds to the surveillance that we need to make sure we're watching these patients. And fortunately, it's not that common, but it does occur. And the one that it occurs to, you want to be able to catch in a timely manner, because it basically takes a very simple procedure of adding another piece that takes you 20 or 30 minutes. And if you miss it or something bad happens, you have a catastrophic event. And so those are the kind of things I think that surveillance has really helped us with.
And of course, in the 10, 20 years since the beginning of this endovascular procedures that we started doing, the technology and the graft materials and everything else has gotten so much more comprehensive.
Oh, yeah.
Fortunately for patients and us, we don't have to do a whole lot of repeat procedures going on and fixing the endo leaks or fixing the graft fractures, or grafts are getting kinked and your blood flow is cut off to the legs. These are relatively uncommon, but incidents that we had to be aware of. This is, I think we spent a fair amount of time here talking about, we reduced this highly complex procedure as we have been successful in reducing the most morbid surgery in our experience, as we know as interventionalists. Yeah. To me, this is one of the most morbid procedures, probably more morbid than coronary bypass grafting that was converted to stenting. You take a 4, 5, 6 hour surgery, what used to be in a complicated cases, now 3.5 hour surgery, reduced it to 1 hour, reduced the morbidity significantly by endovascular methods, reduced the patient other side effects, including blood loss, including impotence, including morbidity and ileus, and all these short and long-term problems substantially by endovascular methods. So it is a great victory for medical and vascular medicine in general, in diagnosing and being able to treat it.
And I think one of the nice sort of offshoots of the abdominal experience has been the thoracic experience. And I think you would talk to even thoracic surgeons where this would be a lot of them their livelihood, and have really that's extremely morbid procedure. That has a high complication rate. It's got a very, very high paralysis rate. And here is a very, very simple procedure in comparison that really you can send these people home the day after or 2 days later with really an incision in their groin. And I think even the surgeons that would tend to balk us on some of these abdominal cases, they love this procedure. They think this is really a godsend, because this surgery is a big surgery. It carries an enormous amount of complications, and I think patients do tremendously better in the thoracic arena. And I think that, and from an endovascular standpoint, it's much easier for you and I to do than a belly aneurysm. It has a little bit more complexity in the patient care standpoint, but in the actual procedure standpoint,
basically a tube.
Much easier to do. Much good. Thoracics, very simple to do in comparison. You don't have to try to navigate into an extra gate. You use basically a wire.
You're not worried about jailing or clipping any of the major arteries like you would as in the case of an abdominal aortic aneurysm. So thoracic aneurysms are certainly that's a whole.
Now that's a much rarer cat. I mean,
it's
that's
a rarer deal.
50,000 abdominals versus 5,000 thoracic. So you don't see very many of those.
It's just a lot smaller incidence. So tonight we successfully completed this 1 hour discussing about abdominal aortic aneurysm, both the diagnosis and treatment. The incidence of abdominal aortic aneurysm, which is somewhere diagnosed closer to 200,000 patients, of which we get to treat so many thousand patients by endovascular method. And as time went by, the treatment modalities shifted significantly from open surgical repair to endovascular repair. So we spent a substantial amount of this program talking about endovascular repair and the ease of the procedure, as well as the headaches, as well as the follow-up endovascular procedures. And also we ended up spending some time about the patients that are susceptible. Again, we reiterate this again, the same patients that have all cardiovascular problems, smokers, diabetes, uncontrolled high blood pressure, family history of aneurysms, male sex, of course, having a skewed response, like all cardiovascular conditions, have a substantially higher incidence of AAAs than African Americans, have a lesser incidence than Caucasians. So it's a significant discussion, and in the interest of time, we will shut it down. And thank you for tuning in and watching this program. And I thank Dr. Fail and Dr. Arzola for joining me tonight in this program.
Join us for the Cardiovascular Institute of the South's From the Heart, live May the 10th at 6 p.m. on RTV KDCG.